Hello to everyone. And as Patrice said, I'm new to the Chiari community, and I've been seeing patients for a few years, but I'm more so on a regular basis over the last few months. Um, and certainly I've had many interesting observations, and would like to talk a little bit about my perspective as a neurologist in seeing these patients. Particularly, I'm trained as a neuromuscular specialist, so I specialize in nerve disorders. I changed the title around a little bit, just you know, to reflect a little bit more specificity towards uh, Syringomyelia patients and Chiari patients. So we're going to talk about a general approach to neuropathies and neuropathic pain in Chiari and Syringomyelia patients, but also expanding TDS and take it a little bit further than that, actually. And very important. This is a neurologist's perspective, so I'm not a surgeon. My job is mainly, diagnostics and you know mainly medical treatments and things like that. So it's a little bit of a different perspective on things. And I'm also really a clinician. I my day is spent seeing 20 to 30 patients a day. I'm not very involved in research or anything like that. So a lot of what I talk about is clinical observations, and that should be very clear that many of the things that I say are just observations and don't necessarily have large studies or anything behind them. Um, uh, so just to start out, oftentimes I start out my lectures with this painting, and it's a it's a painting of a very famous painting called "The Clinical Lesson at the Salpêtrière," and the person giving the lecture is actually Jean-Marie Charcot, and he's probably the father of modern neurology. And the painting has a lot of interesting things. There are some really famous neurologists in the painting. Here we could see Joseph Babinski, uh, George Gilles Charette is sitting here. The painting used to sit over, at least a copy of it used to sit over Sigmund Freud's couch when he would give examinations. And the way they describe the patient, the description of the patient is a hysterical pose. And I always wonder if there was more technology, would they not be calling this patient hysterical? And could she be having seizures? Could she be having orthostatic intolerance? And it kind of reflects that, oftentimes when people have complaints, we may not know the answers because we just don't have the information at hand or the testing at hand to really come to a diagnosis. And we're certainly, in all areas, especially in neurology, as genetics get better and immunological studies get better and imaging gets better, we're always learning new things, and things that we couldn't explain now have certainly better explanations. Um, so let's just talk a little bit about neuropathic pain, and I think there's an important terminology distinction. Oftentimes people come to me and they say they have neuropathy, and what they're describing is they have pain in their feet, they have numbness in their feet. So they really have what are neuropathic symptoms. And this could be sometimes either my Syring's patients or even some of my back pain patients. Neuropathy, especially to a neurophysiologist, has very specific meanings based on the findings on the EMG. So I think there should definitely be a distinction. Sometimes people are told they have neuropathy, but really what they have are certain signs and symptoms, but not actual, clinical proof of, neuropathy. But if we look at neuropathic pain in Syringomyelia, there was a study done by Dr. Millerad, a paper published where he looked at 130 patients with Syringomyelia, and a high percentage of them did present with neuropathic pain, 37%. Of the 37 patients that had surgery, 22 had an immediate response to surgical treatment. Some had temporary responses, some had more, some had responses afterwards. But it definitely tells us that, pain, in Syringomyelia, pain is certainly a predominant feature. But there are always other causes, and that's very important. And that's kind of one of my roles when I see patients is looking for other potential causes. So what are some of the potential causes that I might be looking for? So certainly neuropathy is and we're looking for both small fiber and the large fiber neuropathy. We'll elaborate on this a little bit more later. We can certainly have radicular pain, so somebody may have a pinched nerve due to a disc herniation or arthritis at the facet where the nerve is coming out. Spinal stenosis can often mimic neuropathic pain because spinal stenosis would be a narrowing of the cord centrally, catching nerve fibers all coming down. You can have peripheral nerve entrapments, very common things. Carpal tunnel, cubital tunnel, which is at the elbow and is the ulnar nerve. So you would get numbness at the fourth and fifth digits. Tarsal tunnel syndromes, all sorts of things. Certainly tethered cord can present with burning in the feet. I always try to be aware of peripheral vascular diseases, as a cause of peripheral nerve pain, or sometimes claudication-like pain, where they get intermittent pains when they walk. And this isn't an exclusive list. I mean, the list really can go on in terms of, potential causes. So it's always important to know what other co-founding conditions are present. Number one, because you go ahead and go for a surgery for the syrinx, the pain doesn't get better, and sometimes that's because there may be other causes. And so pre-surgically, it's important to know so we can manage expectations. But post-operatively also, while it may be important to operate on the syrinx, it may need other treatments may be necessary. When a patient comes to me, what are some of the types of testing that we may do to look into things? So obviously the most important thing is the neurologic exam and checking people's reflexes, checking their sensation, seeing their balance, how they walk, and all these things are it's really the most effective way of identifying who has problems and who doesn't. Then, in my world, the EMG and nerve conduction studies is very important. That's what I do. It's my bread and butter. And it gives me a lot of information as to the function of the nerves. And it rules in or rules out many, many different conditions. Similarly, we want to look at the to look structurally at the spine. So and see that, apart from are there other things like spinal stenosis or other things that may be causing pain. Sometimes evoked potentials and peripheral vascular studies could be important. Blood work becomes important in looking for secondary causes of neuropathy. And then we'll talk in more detail later about small fiber nerve biopsies. And then autonomic testing can also be very helpful in identifying small fiber nerve problems. So these are most of the the general type of tests to investigate secondary causes. We'll talk a little bit more detail about nerve conductions and what exactly do we measure when we do nerve conduction. So basically, very simply, we stimulate the nerve peripherally and we look at the muscle response. And usually what we do is we do it at 2 points, and therefore we measure a velocity across this area. We look at a velocity from the last part to the muscle called the terminal latency, and we look at the amplitude of the muscle response. And we take all this information, and then we also look at sensory responses, and we take all this information to kind of, understand what's going on. We also do a needle EMG, and we look at we put the EMG at rest, and we look for abnormal spontaneous activity, and then we ask patients to kind of move and activate their muscles, and we look at how people recruit motor units on active movement. And based on the patterns, that also gives us information about how the nerves and the muscles are talking. What are some of the EMG findings in Syringomyelia? So remember, EMG is a test of peripheral nerves. And oftentimes it's normal because the syrinx is a central problem. So the nerves may be normal, especially early on. Sometimes you may see what's called prolonged F waves, which is a long latency response that we look at. So we're looking at basically, let me see if I could go back. Just 1 second. I'm sorry. So the F response is looking at a volley. So basically, we open up the time spent that the machine records, and when the nerve fires, it fires back and forth. So the F response is, I'm sorry, back and forth, and the F response is the volley that occurs from the spine back to the muscle. So if you do have a central problem, sometimes that'll show up as a prolonged F wave. We may see some increased spontaneous activity on the EMG because some of the nerve fibers die out. And as you know, but really it should be relatively normal. As advanced diseases happen and you start to get muscle atrophy and things like that, you may see, further changes. But like I said, really, if in an early patient with Syring's who has a normal exam, their EMG should be relatively normal as well. Now, again, neuropathy is just an anatomical diagnosis. So if let's say we do an EMG and we find that a patient has a neuropathy, that only tells us, it's like telling somebody they have a headache. You could have a headache because somebody hit you over the head. You could have a headache because you have a brain tumor. And it's the same thing here. When we determine someone has a neuropathy, it doesn't necessarily tell us what the cause is. There could be many causes. It could be vitamin nutrition, so diabetes. It could be a vitamin deficiency. It could be an autoimmune condition. So there are all sorts of things to investigate. Also, very important to distinguish large fiber versus small fiber neuropathy, and this is a lot of what we're hearing now. So large fibers are the main workhorses in the if you imagine your nerves are not just a simple wire. You imagine if you took your house and you had your telephone wires, your cable wires, your internet wires, wires going back to the electric company, giving them information about things. So you have information traveling in both directions at all different speeds in one cable. And that's what a nerve is. It's multiple different wires. And you have large myelinated fibers that run very fast. And then we have these small fibers, which are much slower. And the small fibers tend to transmit painful signals. And the best example of this is if you imagine when you step on a tack, there's that initial lancinating pain, that very quick pain you get. That's the large fibers talking, and they're sending the signals back to the brain very quickly. Then followed by that, the small fibers are running at a much slower rate, and that's kind of that burning pain that you get after you step on the tack. And it's important because small fiber neuropathies are not detected on the EMG. And if you imagine, it's like all the nerves are in a marathon. If you have a photographer standing at the end of the marathon, he's really only going to take pictures of the first couple of, or the main focus is going to be on the winners, right? The first couple of people. All the stragglers in the back, he's not going to see. So even though they're firing, the EMG isn't going to record that information. So the question is how then do we diagnose small fiber neuropathy? Well, part of it is, it used to be just, part of it clinically. So people would describe a burning type sensation in their feet, autonomic dysfunction, heart rate variability, GI discomfort, things like that. Nowadays, we have small fiber nerve biopsies, which are very helpful, and we'll go into more detail about that. We also do autonomic testing, and there are some really exciting things like confocal microscopes of the cornea, which there are small fiber nerves there. So there are all sorts of new and emerging technologies in how we can look for small fiber neuropathy. What do we do when we do a nerve fiber biopsy? And this is I spend a lot of my time doing. It's a very simple thing. It's a simple 3-millimeter punch biopsy of the skin. We anesthetize the area first. That's probably the most painful part. And we take a small punch of the skin. It then goes under confocal microscopy, and we look at the density in the intraepidermal nerve layer. We look at the density of the small fiber nerves. And when we see an absence of nerve fibers, then we look at the age-related, we match it up against age-related findings, and we compare it. We compare the specimen we have to a normal finding. Now there are some significant limitations right now to small fiber nerve biopsies, and I'm always weary of this when I when I read the results. And certainly you can have patchy distribution. So not everybody has the same density in every part of their leg. Part of the way we do this, we account for this is by doing multiple biopsies. So I do 2 sites. Some places do as many as 3 sites. But that can be very helpful. Also, there's some lack of standardization amongst laboratories, and that's an important thing as well. And it's something that eventually will have to correct itself. One other way that we now look at, when I look at the nerve fibers, I don't only ask for the intraepidermal nerve fiber layers, but I also, if they do have sweat glands, you can also look at the sweat gland density, because those are autonomics, which are also small fiber nerves, and that could be very helpful as well. This is I took this from an article by a Dr. Todd Levine, who is out in Phoenix, Arizona, and runs a neuropathy center out there, and has really done a lot of the work in small fiber neuropathy, but not just diagnosing, but also clinically. And what we're what we're finding is that small fiber neuropathies are not just in patients with burning feet, and that a lot of other disorders, we're seeing low small fiber nerve densities when we do the biopsy. So particularly we're seeing it in more widespread pain syndromes like fibromyalgia, again, autonomic dysfunction, but even in things like chronic fatigue and things like that, we're also seeing low small fiber nerve densities. And it's hard to know what exactly that means, but it starts to suggest that there's a syndrome, not just one particular disease, and that people may be affected in different ways. And where the small fiber nerve biopsy can be helpful in all these ways is sometimes if it comes back positive, it might help bolster a diagnosis. Interesting. I was reading an article, and some of the chronic fatigue, they think, let's say somebody has, and models of, they're seeing these models in patients of sarcoid. I actually think I'm dealing with one who just had COVID, but people are having, so they may have, more small fiber disease or more pain, but then some of the wider spread inflammation may be in the hypothalamus, and that may be why we get some of the cognitive dysfunction, sleep, and chronic fatigue and things like that. Some of it may also be autonomic related, which is also mediated by small fibers. So it's really fascinating, and I think this is, certainly, understanding these syndromes and what's behind them is going to be, help us tremendously in treatment. Just when we do diagnose someone with small fiber neuropathy, most importantly is to look for secondary causes, and this certainly is a good list, but not exhaustive, of some of the causes of small fiber neuropathy. And certainly when patients come to me and they have a positive small fiber biopsy, or even before that, it triggers off a whole host of blood work to be checked. Another algorithm of how we may approach neuropathy, evaluating neuropathy patients. And just to bring it in a little bit more towards the Chiari, Syrinx, and the related disorders, this is an article that was published in 2016 in Neurology, and it looked at patients with EDS, and it looked at their small fiber nerve biopsies. And, they collected 24 patients, with mostly with hypermobile EDS, but with other varying types. One patient was excluded for I'm sorry, the typo. It's sarcoid. 23 were women, 1 were men, and they all had normal nerve conductions. Only one patient was asymptomatic, and all of the patients had reduced intraepidermal nerve fiber densities. So I think there was probably some selection bias in this, but it's certainly, that all the patients came back positive. But I think it definitely goes to tell us that, it is prevalent in patients with EDS and Chiari, and it's something that certainly in patients who are symptomatic should be checked for. And the other interesting thing is that the level of nerve fiber density did not correlate with the severity of symptoms. And actually here it also, I don't know how easily everybody can see this, but it's it shows all the different spectrum of symptoms that people registered when they were complaining. Obviously the most of them, and the green is where most of the patients would be, and most of them had skin sensitivity and pain and things like that. But obviously we see GI discomfort, dry mouth, and constipation, and all sorts of autonomic symptoms as well. What are some of the treatments when, and again, when I say treatments, I'm talking about some, treatments for just for small, for neuropathy and small, particularly in small fiber neuropathy. And obviously, some of them are um, the symptomatic treatments, but mainly for pain, but also, the dysautonomia part of it. But really what's most interesting to me is the use of IVIG in small fiber neuropathies. And this is a paper also, again, from Dr. Levine and Dr. Saperstein, this group out in Phoenix. And I had seen this abstract about 3 or 4 years ago when they presented it at the American Academy of Electrodiagnostic Medicine. And it really, opened my eyes to this whole idea of there being this syndrome within small fiber neuropathies. And it's related to can be related to a lot of different autonomic, a lot of autoimmune syndromes, and their use of IVIG in treating these patients. And it really got me to start to think about how I could use this to help, some of my patients who maybe have come in with unexplained burning and things like that, and how to treat them. As far as what is IVIG, it's purified immunoglobulin from donors. We don't know the mechanism of action in terms of autoimmune conditions is not definite, and somehow it shuts down the immune system or it blocks the immune system. Usually we give it as a monthly infusion. Important is we start at a slow rate. We also sometimes pre-treat with things like prednisone and Tylenol and things like that due to viral-like reactions during the syndrome. Some of the risks are allergic reactions, so we always check an IgA level before. Renal disease, which is much less common because of the newer formulations are not in sucrose anymore. But we could also see thrombosis because of the hypercoagulability if you have a patient who has congestive heart failure due to the volume. So those are some of the risks. One of the most important things, obviously, is the cost. And this is from an article about a woman who was getting IG for an autoimmune condition, and we see just how much it could cost, and not just to the insurance companies and the overall burden on the head, but to the patient. Even though it's panacea, all sorts of conditions, often IVI have to be judicious, give it to, and really keep evaluating people are getting. Not we're not overburdened with costs. And is a way of, as I was preparing this lecture, and reading through certain articles, thinking more about, and also seeing patients with Chiari and and Syringomyelia and the related disorders, thinking about all the different things that come together in terms of, the mechanical aspects, Chiari, craniocervical instability, Syringomyelia, Ehlers-Danlos, and then some of the nerve-related dysfunctions we have, the immunologic relate, and thinking of them as kind of all combining, and based on genetic, immunologic, and environmental and even infectious factors, kind of combining together in different mixes, and that gives us the spectrum of patients that we see, day to day. So I think that's the most intriguing part of this, is to try to figure out, and we'll talk about it in a second, what is it, you almost think that could small fiber be the thread that binds it together. I don't believe so. I think there's probably things that are beyond that, and certainly with certain G-coupled receptors. So we know that, we see, there recently there's been a breakout of information about what's called CGRP, or calcitonin gene related peptide, and its treatment of migraines. but we find that receptors are on small fiber nerves. Receptors are found on mast cells. Receptors are even found on bone cells. And it would be, so fascinating, to one day see if there's something, that ties these all together, not just for the purpose of just academics, but also for the purpose of finding, therapeutics that kind of get to the core of a disease. So what are some of the areas of exploration that we need? Obviously, well-designed trials for IVIG, for treatment, reliable diagnostics, standardization of techniques and labs. We also have to know about who would benefit from IVIG. Are there certain patterns of small fiber loss, that it would be indicative of a certain phenotype, or certain patterns of a phenotype? Are certain symptoms more amenable to IVIG? And again, as we discussed, what is the common thread in small fiber, between all these things? And the best example I can give is, myasthenia. We're making tremendous gains in, like I said, I'm really trained in neuromuscular diseases, so I also treat myasthenic patients. And in myasthenia, which is an autoimmune condition, we always focused on the neuromuscular junction. Then all of a sudden, a few years ago, we started to focus on complement, and we have new medications like Solaris, and we were able to treat a wider group of patients, because we were getting to the core of the disease, and we were able to treat them better with less side effects. So we weren't using a sledgehammer to hit a fly. And now recently we found this FCN receptor, and there are therapeutics being targeted for myasthenia, and we think that that's a more earlier part of the chain in the development of neuromuscular of myasthenia and other neuromuscular junction disorders. And we're seeing that those patients who don't have antibodies in myasthenia, who were generally did not respond well to these treatments, are responding better to these FCN receptors. And it's part because, again, I think as we get closer and more precise understandings of diseases, our therapeutics get so much better and so much more targeted. So that's the end of my presentation. And thank you everyone for listening.